noches. Good evening, everyone. My name is Mariana Atencio. I'm a Peabody Award-winning journalist and author, and I'd like to begin by thanking Enrique, by thanking Sergio, and of course by thanking Amir Dosal, who is still here in the room, for the privilege of having me moderate this conversation and kick off this event on the importance of health equity. Thank you as well to Lili. Thank you for your leadership and your commitment to addressing this issue. So I'm originally from Venezuela, and I know very well from growing up there the importance of tackling health equity and what happens if you don't. As we heard from Amir, it's cycles of poverty and inequality, lack of education that at some points can become unsurmountable. And it all begins with health. Later on in life, as a reporter, I get sent, as I always say, not to cover good news, that never happens. I get sent to areas where there's devastation, war, turmoil. I got sent, for example, to cover the earthquake recovery in Haiti. And when the social determinants of health have not been addressed, when there is health inequity, is when that devastation or that natural disaster can turn into a full-blown crisis that has the potential to really crumble an entire nation. So that's why we are here. We are here tonight at the United Nations to say we can do better, to say we can avoid this. We are the leaders who are going to be that change in the world because we know better. And talking about leadership, we have gathered some of the leading minds in health from around the world, and I'd like to welcome them on the stage now to begin this conversation. First of all, we have Gerald E. Johnson II, Executive Vice President, Health Equity and Chief Diversity Officer at the American Heart Association. Big round of applause. I'm going to ask you to get on here, stage right. Second, I'd like to introduce Neela Montgomery, former President and EVP of CVS Pharmacy, Board Director of St. Jude's Children's Research Hospital, Logitech, and Squarespace. Neela Montgomery, everybody. And last but not least, we have Dr. Stephen Shaya, Executive Servant Leader at J&B Medical. Stephen, welcome. So I'd like to jump right into the conversation to take advantage of the time we have with some examples. You know, what are those sort of, bright spots in terms of this conversation? Because the pursuit of health equity is challenging, it's complex, but when we talk about these private and public partnerships, where is progress being made? Can you share which partnerships you've seen are delivering results? I'll start with you, Gerald.
Yeah, well, thank you, Mariana, for having me. Thank you all for being here. The first thing is framing it. You know, in order to fix something, you got to call it what it is, and you have to align people around the fact that there's a problem. At the American Heart Association, we've recognized that through science, we've determined that all of these issues affect life expectancy. So think about it for a moment. People that live maybe a mile or two from each other have a 10 or 20 year life expectancy difference because of the social determinants of health. And the only difference is lack of services, lack of partnerships, lack of investment, lack of actually calling it what it is. And so one of the things we're doing that talks about public-private is this notion of creating social impact funds. And so you think about that, it's an impact-first concept. We're working with philanthropists, investors that really care about these issues. These are wealthy individuals, family offices, and companies that really care about under-resourced communities. They care about those that can't afford to live the life they'd love to, and they care about communities where, in some instances, they say, if you get sick, don't go to this hospital, go to that hospital. If you've ever heard that, that's part of this conundrum that we're trying to address. And our social impact funds specifically focus on access to care. They focus on recidivism. They focus on food insecurity. They focus on all the things that science. And it's important that you think about this. Science says that 80% of what goes into someone's life expectancy is affordable housing. It is transportation. It is nutrition. It's clean air. It's all those things. And so our social impact funds focus on raising capital and deploying that capital in communities around the United States, investing in entrepreneurs that are female and entrepreneurs that are diverse, because most venture capital money Back to root causes, do not invest in women, do not invest in entrepreneurs of color. So removing that barrier and focusing on the social determinants of health. And today, there are examples of where millions of people now have access to care. There are millions of pounds of food being distributed and sold in neighborhoods where fresh fruit and vegetables didn't happen. And if you think about state recidivism levels at 40, 50%, some of the organizations we've invested in are driving 6, 7, 8, 9% recidivism because of the training, because of the investment, because of helping people re-socialize into society. So some examples of the benefit of social impact funds at the American Heart Association and the power of public-private partnerships.
Thank you for that. I love that you mentioned the framing, because as a journalist, you know, when you're communicating these stories and trying to humanize this issue, there's a lot of misinformation. And it is an issue, like many issues today, that does get politicized. So the importance of framing it correctly and really getting to the root causes. Neela, as we just heard, you know, when Gerald was talking about investing in communities of color, women of color, you are oftentimes first one, only woman of color in many of these rooms, sometimes making these decisions. What are some of those examples, or one example that you have seen is a bright spot in this conversation?
Yeah, well, I think it was actually mentioned right in the intro, which is if you had the privilege to live in America during the pandemic, despite many of the challenges that were experienced, we did have abundant vaccine. It was developed using mRNA technology that was, you know, created here in my home city of Boston, driven by a very vibrant biotech private sector that developed that vaccine within weeks. And it was then distributed through private companies, one of which I happened to run at the time, which was CVS Pharmacy. And most Americans lived within 5 miles of a venue. And apart from the initial weeks where there were some shortages, if anything, what actually happened was that, you know, we expected people to resist taking the vaccine because of distrust of the healthcare system, traditional inequities, for it to break along race, and the community leaders came in and worked with us to support that and to drive it within their own communities. And that is a clear learning, which is you cannot drive these outcomes without communities and leaders, one zip code at a time. Instead, it actually fell along political lines, and there turned out to be resistance for different reasons. Mm-hmm. But it was probably, I think, one of the best examples that we will ever see at scale of public and private working together.
That's absolutely on point. And when you talk about the ability to drive change through those partnerships, it was displayed through this health crisis that was truly global. And then the difference, as we heard in the beginning, from the places that really were able to develop it, and then those places around the world that didn't have it and didn't have that structure in place. Dr. Shaya, tell us about your experience also from a family office perspective.
Well, first, I wanted to thank my fellow panelists, Sergio, Enrique, Lily, the whole team. I especially want to thank my mother, who allowed me to come at the last minute. I hope someone's recording this. I love you, Mom. So we look at this in a unique framework. So there's a famous Jewish scholar called Maimonides, and he talks about something called tzedakah. And there's the 8 levels of giving or charity. And the highest level of giving or charity is helping someone in a partnership get out of their dependency. You know, everyone thinks, oh, I give money, I'm good. Okay, well, there's nothing wrong with that, but the highest level of giving is giving intentionally and forming partnerships. So how do we see that? I'll give you 2 examples. One is we used to give a lot of money to veterans, because that's something near and dear to our hearts. Instead, now we have 103 service-disabled veterans with disabilities that work for us today in a unique partnership in Atlanta, Georgia, with Bobby Dodd Institute. 38% of people that leave medical service are unemployed. And you might say, how is that possible? Because they're used to structure, someone telling them where to eat, where to go, what to do. And so by giving folks, I can't even tell you how many folks that were in the dormitories in the VA, basically homeless, now you give them jobs, you give them an opportunity. The second example is we have a partnership with the Navajo Indians. So we won a contract, a large contract in New Mexico, where we're taking care of 70,000 Medicaid patients in New Mexico, one of the sickest populations in the United States. 25% of that population is over the age of 65. And now in this partnership, we're also going to be taking care of 400,000 Navajos in Utah, Arizona, and New Mexico. And not only is it a true partnership where we have a location there, we're going to have hundreds of people. We have 25 people currently today there. But we also set up a school to train people for future skills. So for example, home health. That's a huge problem area. Phlebotomy, certain skill sets, behavioral health, therapists. So when you give people jobs, you give them opportunity. I think when you talk about health equity, let's talk about giving people meaning and purpose. If you give them meaning and purpose, I think you give them a reason, I think that's a big step forward to tackling the issues.
Thank you so much, Dr. Steven. Thank you for your passion. We also say hello to your mom. Hey, Mom, watching at home. A lot of the examples you mentioned, the VA working with the Navajo Indians have to do with policy. So let's now move the conversation over to policy. Gerald, I'm going to start with you again. Why is policy important to address health equity, and how can public-private partnerships advocate for this issue regarding policy?
Yeah, first of all, one of the fastest ways to drive change is by passing laws, where it's unavoidable and there's no questioning whether or not you should do it. So policy is always going to play a part, right, whether it be local, state, or federal. I'll give you a couple of examples, and then I'll give you a reason why we're not doing enough. So if you think about this notion of economics, one of the root causes of health equity and equity issues is access to capital. That's a whole nother meeting, a whole nother time with a whole bunch of other people. But one of the things that policy can do is think about things like addressing free meals for kids that come from neighborhoods and families that can't afford to have nutritious meals all the time. That can be a policy. It is a policy now, but under-delivers on its potential. Another example is this notion of Medicaid expansion. Many of you have heard it, and we've talked about COVID a little bit, but many states now are actually retracting it. So for all the gains that we saw, you're actually going to see the reverse pretty soon. And so policy around making sure that everyone has access to reasonable coverage shouldn't be optional based on the size of your wallet or where you went to school or your zip code, but it is. And then the last one I will give you is around things like clean air and smoke-free, right? Where you have strong policies, you see better health outcomes. And then I'll give you an example. Many of you have flown out of LAX, right? Big airport, Inglewood, all the way around. It's 24/7, doesn't stop. Amidst all of that are schools. I spent several years out there living and working, and I would hear the planes, see the planes, and see the fumes coming down where all the kids are. So there's a zoning opportunity if we would pass laws. Contrast that to John Wayne International Airport. Don't know if you've ever flown in, but after a certain time at night, you can't fly into there. Equally important, the pilot tells you that when you're going to take off, you're going to immediately ascend up and out, because Orange County is one of the wealthiest. Orange County is one of the most well-represented at a policy level, zoning level, and the voice of the people are being heard. So it does work. The question is, in neighborhoods where equity is an issue, you also have transportation issues. You also have family income issues. You have per pupil funding issues. You have affordable housing issues. And all of those things work together. They're called structural issues. And the AHA, as an example, wrote a paper on structural racism and how it looks at policies and systems and social norms. And for those that are counting, I didn't say individuals. I said policies, systems, and social norms that often work together to disenfranchise those of lower income, lower education, and most often race and or sexual orientation. So when I think about the power of policy, there are examples that work, but we're not going deep enough and we're not going wide enough. And this spirit of companies working together in communities is a really fast way to do that.
And I will never see airports the same. Yes. Neela, your career has taken you all over the world. When you look at policy and the policy changes that are necessary to promote health equity, how would you compare the examples that Gerald just gave to other places where you have lived and worked?
Yes, I mean, as you can probably hear from my accent, I grew up in the UK, where we have a national health system, much criticized, but also significantly lower percentage of our GDP in the UK is spent on healthcare for significantly better outcomes. So why is that, I think, is the question. I sit on the board of the largest Medicaid plan in Boston, in Massachusetts. And I think what people don't recognize enough in the US is we have 90 million people on Medicaid in this country, another 40 million on affordable healthcare. We have a version of socialized medicine. It is the #1 cost for every single state. And yet, this has become a political football. And I really, it puzzles me, if I'm honest, because we need to engage with how we deliver Medicaid care. We need to deliver care, but we are struggling because there is such a distrust of the health system. There is still an access issue despite the levels of insurance. And there is clearly a big shortage of workers. So what I would say is we really need to learn from others, but accept that we have a socialized Medicare system, or Medicaid, and start managing it as such and being politically vocal about that. It's very kind of demoralizing sometimes that people really can't run on well, other than Bernie Sanders, obviously, can't run on a broader access to healthcare conversation because they know that that's going to affect them in the polls. And that is just not, that is not what we're here to do. We need to have proper policy conversations. And then the second thing, and I want to build on what Gerald said, we need to go further up in the value chain. So it's not just about school meals, it's also about teaching kids nutrition in school. The #1 killer in this country is obesity. 25% of seniors have diabetes, but when are we actually teaching people to make healthier choices? They do that in Europe. I remember my kids learning that when they were 4 in Germany. It's just considered part of being healthy much earlier in your life.
Dr. Shaya, I'm going to move on to the next question because this is going to fly by, this conversation. Let's talk about the challenges, and we've already touched on several, but what are the barriers that you see to public-private partnerships when working towards health equity, and how can these barriers be overcome?
So today, U.S. healthcare is $4.2 trillion. If you put in perspective, we are the 4th largest economy in the world. By 2025, we will be the 3rd largest economy in the world. By 2030, $6.8 trillion on U.S. healthcare. So I want you to understand that. Now, out of that, 10 to 20% of that pie is medical care, actually going to the doctors. The other 70 to 80 to 90% of your health is based on non-medical factors. So when we talk about that, people like to say social determinants of health, food, transportation, financial. Now what needs to happen, and the challenge is the incentives today do not align with what we need to do. So how are we trying to change that? So in the state of Michigan, this next RFP for Medicaid, the incentives for getting the information around social determinants of health, just getting the information. So on a $2.1 billion health plan now has 5% of their budget, almost $100 million, based on them actually screening the patients and getting something called a Z code. So the first thing that needs to happen is we need to look at the incentives and how providers are paid. And guess what? If you give them incentives to get this information, then they're more likely to do something about it, okay? The second thing is, you know what innovation is in healthcare? it's integration. The problem is people come up with all these great ideas and all these great gifted gadgets, solutions. It's all sexy. It's great to talk about. You can raise a lot of money, but they don't know how to weave it into the delivery of care. And so I think they're in these partnerships, not just public-private partnerships, but it takes the entrepreneurs, it takes the providers. We all have to be simpatico, and that's what's missing. The system is so fragmented that you can't integrate a lot of these things, but it starts with the incentives. Because at the end of the day, everything sounds great, but if the money does not align with the efforts, people may do it for a while, but it's gonna flame out.
So we only have time for one more question, and I'm going to start with Neela to close this out. This question, I love the framing of it because it's kind of called a magic wand, right? We're here to talk about health equity. This forum is an amazing platform. So Neela, what would you like to see the forum doing or executing that takes our impact to the next level?
Yes, I'm actually going to build on Stephen's point here, which is I really think the issue is we don't have integrated care systems and we don't have community health. And actually, very few people are incentivized to deliver community health because the way our system works is that the life is not kind of owned for, an average commercial life is like 3 years. So me stopping you getting diabetes 10 years down the road is not incentivized, right? So I think the magic wand is clearly how do we create integrated care systems that work financially for all different parties so that they're not competing and that they can really deliver this care within the community.
Magic wand for Gerald.
Yeah, I totally agree with both of my panelists around the incentive thing. That's a magic wand in and of itself. But I also think there's an opportunity to rethink what we're spending money on. And there's this notion of symptoms versus root causes. And then I'll tell you what I mean. So when we get headaches, we have a tendency to take an aspirin. But what we're not really dealing with is what is our body trying to tell us in giving us the headache in the first place. So squeaky wheels, get the oil, all that wonderful stuff. I'd like to see us really start thinking about root causes of why we're offering people meals, root causes of why we're subsidizing the fact that housing needs to be subsidized, or the fact that there's millions of people who actually have care, but they can't afford their copays. So root cause back to capital, access to capital, living wages, and the ability to afford a life that shouldn't matter based on the zip code that you live in, one magic wand. And then the other is partnership, right? So we're here in this forum, this public foundation is terrific. I'm a member of the World Economic Forum and the Global Health Equity Network, and a couple of my colleagues, John, he's here as well. I know he's going to talk about that as well. This thing is too deep and too wide for one organization to think that we can do it ourselves. What we can do together, let's do it and be intentional about it, even if it means each of us get less, but we'll be able to do more. And then the last thing is, how do we tell this story? There is some amazing things going on. And you are a world-class, journalist. You know how to tell stories. But this space needs better experts to tell the story, to get more people informed. And I find that the news that isn't data-based and fact-based is actually superseding what's really going on. So data, sharing that story and allowing people to make choices for themselves is another powerful thing at the community level.
Thank you for recognizing that. The power of stories, that's what really generates change. That's what creates history or collective memory. And it's data and also getting on the ground and finding those stories that can really humanize the data and can get a person that's watching in another state say, wow, that could happen to me, that could happen to my family. So I'm going to call on my representatives to take action on this issue. Stephen, over to you now. Your magic wand, and why does this matter? What we're doing today, how can we take it to the next level?
Well, humanity and health are not political footballs. They should not be politicized, first and foremost. We got to put the human back in humanity. We got to put care back in healthcare. We're all divine beings on a human journey. If you give people health, you give them hope. And you give them hope, you give them everything. And I truly believe we have to start from there. And every person in this world deserves affordable and accessible healthcare, period. Now, we can disagree about how that's delivered, but it has to start from there. And if we don't start from there from a core value, then we'll never get there. Margaret Mead said it best. I always remember this quote, never forget that a small group of thoughtful and committed people can change the world. Indeed, it's the only thing that ever has. That's the opportunity we have here today. And I truly believe we can come together and we can go out and make a difference, but we have to care about the people first. It's got to start from there. It's not a political issue. It's not a financial issue. And if you start from there, I believe we can, none of these problems are insurmountable.